Have you ever felt that sort of information overload?
Hmm.
Especially when it comes to really sensitive, complex topics
Yeah.
like your health.
Oh, Jeff.
You want to be truly informed.
Right.
Right. You want to grasp every detail, but sometimes the sheer volume of medical jargon, all that dense info, it just leaves you feeling more overwhelmed than enlightened.
Yeah, it's a common feeling.
Well, you've landed in exactly the right spot. Welcome to the Deep Drive.
Mm-hmm.
This is the show where we take that stack of sources, articles, research, maybe your own notes, and we don't just, skim the surface. Not at all.
Right.
We unpack it. We really dissect it. And we transform that dense material into clear, powerful insights. Our mission, it's simple, really. Give you that shortcut to being truly well-informed.
Get you up to speed.
Exactly.
Yeah.
Packed with surprising facts and hopefully just enough engaging conversation to keep you, well, hooked.
Absolutely.
Today we're embarking on what I think is an absolutely crucial, and I mean profoundly detailed deep dive.
Mm.
Our focus is the approach to a gynecological patient.
A really important area.
And this isn't just about, symptoms and diagnoses. No, this is about mastering the entire journey, the whole intricate process.
From start to finish.
Right, from that very first, often delicate interaction a patient has, through the meticulous exams, all the way to understanding the real nuances of advanced investigations.
Mm-hmm.
We're going to view this whole thing through the lens of gold standard best practices, going incredibly deep, every topic, every concept. Our goal, for you to walk away feeling like you've achieved a level of mastery, like the elite professionals in this field.
That's the aim, really getting into the nitty-gritty.
So why does this specific deep dive matter so much to you, our listener? Well, whether you're a healthcare professional looking to refine your approach, deepen your expertise.
Or maybe just refresh.
Or refresh, yeah.
Yeah.
Or maybe you're just a curious mind committed to understanding women's health at a, frankly, higher level. Yeah. Or maybe you just want to feel more empowered, more confident, more articulate in medical conversations.
Which is valuable for everyone.
Totally. This deep dive will equip you with an unparalleled understanding. What goes into a truly thorough, ethical, and, importantly, compassionate gynecological assessment, and guiding us, helping us connect all the dots and extract the most vital insights from our, extensive material, is our expert.
It's great to be here. And this area, gynecology, it really highlights something important.
What's that?
It shows how that human element, that dance of trust and communication, is just as critical, maybe even more so, than the purely clinical side.
Interesting point.
It's a field that's just incredibly rich with complexity, but also has such a profound impact on people's lives.
Okay, let's unpack this right from the start then.
Okay.
When we talk about gynecology in this deep dive, especially for those aiming for that mastery level, what's the scope? What's the definition we're working with?
Right. Well, the term itself, gynecology, it's derived from Greek.
Okay.
You've got gos, meaning woman, and logos, meaning discourse or study. So fundamentally, it's about the diseases of women, specifically, those related to the female genital organs.
The core clinical aspect.
Exactly. But here's what's fascinating and what our source flags immediately. The initial approach in this field, it's much, much broader than just the clinical stuff.
Broader how?
It's about establishing a real human connection, a foundation of trust. Before you even get to the medical procedures, that initial interaction, it sets the entire stage.
Okay, that leads directly to something our source emphasizes, that patient interaction in gynecology is often anxiety-producing.
Mm-hmm.
Why is that particularly true here? And what's the physician's main responsibility in dealing with that anxiety?
Yeah, that's a really important question, isn't it? Why so sensitive?
Mm-hmm.
It's because the problems discussed are just intensely personal, often involving the most private aspects of a woman's body, her sexuality, reproduction, sometimes very delicate emotional or social things, too.
There's a definite vulnerability there.
Absolutely. So because of that, the physician's role in establishing rapport is, it's paramount. It's not just about being nice. It requires observing the highest standards of ethical and professional behavior. The goal isn't just collecting data. It's about cultivating an environment where the patient feels genuinely comfortable.
Comfortable, not judged.
Exactly. Not embarrassed, not hostile, not judged. And it's that deep comfort that allows for a truly meaningful, accurate assessment of whatever the underlying medical problem is.
Because if that trust isn't there from the start,
then crucial information might get held back, maybe even unintentionally. And that can seriously impact the diagnosis, the treatment effectiveness. It's the bedrock, truly.
that makes total sense. So building on that trust, our source outlines 4 fundamental ethical principles. These must be integrated into care.
Yeah.
Let's really dive into each one. They sound foundational for that elite practice we're aiming for.
Absolutely. And they're not just guidelines, like suggestions. They are the pillars holding up the whole thing.
Yeah.
The integrity, the humaneness of gynecological care.
Yeah.
Mastering these is just as vital as mastering any clinical procedure. So first up, privacy and respect. The core idea here is simple but profound. Respecting the patient as an individual. Recognizing their right to make informed decisions about their own health care. Empowering their autonomy.
So how does that play out practically, especially during counseling, which seems so key?
Counseling is a huge part of it, as the source highlights. It means having a thorough, clear discussion about the nature of the ailment. What is it? How does it work? How might it affect her life?
Okay.
Then explaining why certain investigations are needed. What's their predictive value? What might this test tell us?
Transparency.
Complete transparency, and crucially, presenting all the treatment options, laying out the merits and demerits of each one.
The good and the bad.
Exactly. This allows the woman to thoughtfully choose what she believes is best for her, based on her own values, her own priorities. Now, the clinician should guide her, of course, based on medical expertise.
Towards the right decision, medically speaking.
Right. But they must not enforce their own opinion. That's ethically and morally imperative. It reinforces her autonomy every step of the way.
And what about safeguards? I mean, in today's world, there must be medical legal concerns if this isn't done right.
Precisely. Meticulous record-keeping, proper document preservation, these are critical safeguards. In our complex healthcare system, clear, detailed records are invaluable. They document everything.
Covers the clinician, but also ensures clarity for the patient's care.
Exactly. And beyond the paperwork, the patient must always feel deeply assured of privacy and confidentiality throughout the whole interaction.
How do you foster that feeling?
Simple things, often talking softly, ensuring conversations aren't overheard, patiently listening to every nuance. It's about consciously creating a safe space, physically and emotionally, making vulnerability feel safe.
Okay, got it. Principle number 2, beneficence. What's the core of that one in gynecology?
Beneficence. It boils down to the medical attendant's constant vigilance, ensuring all advice, all actions are given in good faith and are unquestionably aimed at benefiting the patient.
Doing good, essentially.
Doing good, yes, but it's more specific. Every single medical measure taken should be guided and evaluated based on a cost-benefit ratio.
Financial cost.
Not just financial, it's a holistic assessment. Potential risks versus the expected advantages for that specific patient's well-being. A minor procedure might be cheap, but if it carries a high risk of complications for her with little proven benefit,
Wouldn't be beneficent.
exactly. The physician is constantly weighing what will truly do the most good for this patient. It's very individualized.
Right, focusing on the individual. Okay, third principle, justice. How does that apply day to day?
Justice is upheld when the physician ensures fairness across the board. Access to care, the type of care, the attention given, even the cost, it all needs to be equitable to the needs of the patient.
Meaning no bias.
No bias whatsoever, regardless of socioeconomic status, background, beliefs, anything. It's about fair allocation of resources and attention. Every patient gets the care they need and deserve. It builds trust in the whole system, really.
And the fourth principle sounds a bit more pragmatic, avoiding litigations.
It does sound pragmatic, doesn't it? But it's deeply linked to the others. In modern medicine, yeah, it's crucial to avoid investigations and treatments that might lead to future lawsuits.
Is that just defensive medicine?
Not necessarily. It's more about the implication. It stresses the need for incredibly thorough documentation, truly informed consent for everything, and sticking rigorously to best practices, the things we just discussed.
So if you do the other three well,
The risk of litigation naturally goes down because the patient feels heard, respected, competently cared for, and valued. It's almost a byproduct of good ethical practice.
okay, so with those ethical pillars firmly established, let's move into the clinical process. The source is really clear. Careful history and physical examination constitute the fundamental tools. It says the diagnosis, tests, treatment recommendations all rest on this. How central are these initial steps really? Are they truly the bedrock?
Oh, unequivocally. They are the absolute bedrock. Think of it like building a skyscraper. Without that strong, carefully laid foundation, everything else you build on top is unstable. Investigations, tests, they're powerful, yes, absolutely necessary, but they mostly confirm the diagnosis or help track treatment.
They don't replace the initial assessment.
Exactly. It's that initial clinical assessment,
Yeah.
the rich story you get from the history, the clues from the physical exam that guides everything that comes next, which tests to order, how to formulate the right treatment plan. It's where the art and science of medicine really start to blend.
And this is where it gets really interesting, because the source advises asking the patient to describe her main complaint in her own words and take her own time. Why is that specific patient-led approach so critical in gynecology? What does it unlock?
That approach is just paramount. Its value can't be overstated. Letting the patient tell her story at her pace. It's invaluable for several reasons.
Like what?
First, it lets her describe the evolution of the problem. When did it start? How has it changed? What makes it worse? What helps? She can detail previous tests, how she reacted to treatments. Often patients have this subtle gut feeling, an intuition about their own body.
That a checklist might miss.
Totally. Allowing them to speak freely can uncover vital clues, often subtle things, that a rigid Q&A format would just gloss over.
And the second reason?
Maybe just as important in Gynae. Good and patient listening is essential for getting maximum cooperation later on, especially during the pelvic exam.
Right, which you said can be daunting.
Extremely daunting for many women. If a patient feels rushed, unheard, or disrespected during the history taking, she's going to be far less comfortable and cooperative during the physical exam.
Which compromises the exam itself.
Significantly. It compromises the quality, the thoroughness. It's all about building that therapeutic alliance, that trust, right from the very first words, making her partner in her care.
So beyond that main complaint, what basic info kicks off the record, and what critical areas must a thorough gynae history cover to get that mastery-level understanding?
Okay, the foundation starts with the basics. Name, age, marital status, and the presenting complaints. That's standard.
Right.
Then, we systematically build layers of understanding, documenting crucial aspects. First, the present illness.
Yep.
Clinicians have to record all complaints in the exact order they happened, noting duration, aggravating factors, relieving factors, and crucially, the relation to menstruation, urination, defecation.
So pain worse with periods, or with urination. That's a clue.
Big clues. Also vital. Any prior investigations and the patient's specific response to any previous treatments, it gives you the story arc of the current problem.
Got it. What's next?
Past and personal history. This section is often incredibly rich with diagnostic links. Past medical and surgical problems can seriously impact current complaints. For example,
Give me one.
history of diabetes. It immediately suggests that pruritus vulva intense itching might be due to genital candidiasis, a yeast infection.
Because of the sugar levels.
Exactly. History of an STD. Direct bearing on future infertility because of potential tube damage.
Okay.
Pelvic inflammatory disease, PID, or peripheral sepsis infection after childbirth, often linked to long-term menstrual issues, chronic lower abdominal pain, congestive dysmenorrhea, infertility, because of adhesions.
Scar tissue.
Right. Even something like tuberculosis, if it affects the genital organs, can lead to oligomenorrhea, infrequent periods, and infertility. Endocrinopathies, hormone issues can affect sexual function or periods.
So seemingly unrelated things are actually deeply connected, really highlights the holistic view needed.
Precisely. And it's not just past illnesses. Systemic diseases, hypertension, heart disease, anemia, diabetes, asthma, these are critical to identify and get under control before any planned surgery. They massively impact surgical risk.
Patient safety issue.
Huge. Previous blood transfusions, drug allergies, also vital, especially screening for HIV, hepatitis B, and then previous abdominal surgery. Things like C-sections, appendectomies, removing ovarian cysts, these can lead to pelvic adhesions.
Those bands of scar tissue again?
Yep, and they can cause chronic abdominal pain, backache, a retroverted fixed uterus where it's tilted back and stuck in fertility, menstrual problems.
And painful intercourse.
Dyspareunia, yes, often a direct result. So past surgeries, even seemingly minor ones, can have lasting gynae impacts. You need to ask.
And lifestyle factors. How deep do you need to go there for that professional edge?
Absolutely essential. Lifestyle factors are integral. Drug allergies, all current medications, including over-the-counter stuff, herbals, alcohol use, smoking, drug abuse history, general lifestyle, all directly relevant to planning management.
How so?
They interact with conditions, influence treatment choices, affect recovery, long-term health. You need that detailed picture.
Okay. What about family history? The source mentions things running in families.
Yeah, this points to genetic or shared environmental factors. Menstrual patterns, for example, can be strikingly similar among female relatives.
Mother like daughter.
Often, yes. Premature menopause, heavy bleeding, menorrhagia, painful periods, dysmenorrhea, you might see these in multiple family members. Also, higher risk of certain cancers, ovary, uterus, breast in some families.
Other conditions too.
Definitely. Diabetes, hypertension, thyroid issues, allergies, functional disorders. Even genetic things like thalassemia or infectious diseases like TB if people live closely. It helps paint a picture of inherited risk, guides a more proactive approach.
Like building a genetic map. Okay, now marital and sexual history, this has got to be handled sensitively.
Utmost sensitivity, discretion, empathy. Absolutely non-negotiable. You need details like frequency of intercourse, any pain during intercourse, dyspareunia, issues with arousal or desire, virginity, orgasm, libido, contraceptive use method, and consistency.
Very private information.
Deeply private. And one key connection, always to note. Dyspareunia's relevance to infertility. Pain can prevent intercourse. Or it might be a symptom of something causing both pain and infertility.
So you need that trust we talked about earlier for patients to share this.
Critically, you need that safe space, built with respect and empathy, otherwise you won't get this crucial information.
Now let's really zero in on menstrual history. The source gives almost a vocabulary list. For that mastery level, let's unpack these terms. What do they signal diagnostically? Let's decode this language.
Right. This is fundamental. Understanding these isn't just memorizing words. It's about pinpointing what's going wrong physiologically. We assume normal first period, menarche, and regular cycles are the baseline. The detective work starts with the deviations.
Okay, so first excessive bleeding.
Okay. Historically, menorrhagia meant heavy bleeding, longer duration, or heavier flow, but the cycle length stayed the same. Now that term is mostly replaced by abnormal uterine bleeding, or AUB. It's broader.
Got it. AUB.
Then you have polymenorrhea, or epimenorrhea. That means cycles are too frequent because the cycle length itself has shortened, like going from 28 days to 21 days.
Okay.
And sometimes you get both, shorter cycles and heavier or longer flow. That specific combo is polymenorrhagia.
So how do you judge how severe this AUB actually is? Beyond just the patient saying it's heavy, what are the objective markers?
Crucial question for understanding the impact. You assess severity using several things: number of pads or tampons used per day, history of passing large blood clots, and very importantly, signs of anemia.
Like fatigue, dizziness.
Exactly. Fatigue, palpitations, dizziness, getting breathless easily, pallor, that noticeable paleness. These tell you about the systemic impact of the blood loss. Guides how urgently you need to act. And common causes for menorrhagia and polymenorrhagia are source points to uterine myomas, fibroids, also adenomyosis, where uterine lining tissue grows into the muscle wall. PID can cause it, IUCD sometimes, and hormonal imbalance, what used to be called DUB, now part of AUB, especially common in perimenopausal women with fluctuating hormones.
That's a clear picture of too much bleeding. What about the opposite? Infrequent or reduced bleeding? Key terms and signals.
Right. Oligomenorrhea means infrequent periods. The cycle length that's longer, maybe 35, 40, even 90 days, but the flow duration or amount might be normal when it does come.
Okay.
Then hypomenorrhea. Cycle length is normal, but the bleeding is much lighter or shorter duration, or both, like a period lasting only a day or two, very light.
And then no periods at all.
Amenorrhea, complete cessation of menstruation.
And what causes these?
Yeah.
For that deeper understanding.
Oligomenorrhea, hypomenorrhea, amenorrhea, they crop up in various conditions. Polycystic ovarian disease, PCOD, that's a big one, a complex hormone disorder.
Right.
Hyperprolactinemia, too much prolactin hormone can suppress ovulation. Genital TB can damage organs. Even using oral contraceptive pills can cause lighter or absent periods, that's expected.
Other causes.
Certain pituitary or ovarian tumors that mess with hormones. Functional hypothalamic disorders, issues with the brain's control center. Psychiatric disorders sometimes, occasionally specific drugs. And it's a spectrum. Oligo and hypomenorrhea can progress to full amenorrhea if the underlying cause isn't treated.
Are there ever normal reasons for amenorrhea? Things a clinician would rule out first?
Absolutely. Physiologically, amenorrhea is normal and expected during pregnancy, lactation, breastfeeding, before puberty starts, and after menopause ends. Always rule those out first. Now, bleeding at unusual times, bleeding between cycles or postmenopause. Metrorrhagia, now usually called intermenstrual bleeding, is bleeding between periods.
Okay.
Sometimes it's linked to ovulation Mittelschmerz, but much more often it's linked to neoplasms, abnormal growths, uterine polyps, cervical cancer, other uterine or lower genital tract malignancies.
Serious possibility.
Very. Also, vascular erosions, IUCDs, breakthrough bleeding on the pill. But the source is emphatic. Intermenstrual bleeding demands thorough, prompt investigation because of that real possibility of malignancy. It's a major red flag.
A definite red flag.
Yeah.
What about continuous bleeding, where there's no pattern left?
Continuous bleeding, yeah, where the normal pattern is just gone. It can be functional hormonal disturbances, like sometimes happens during puberty or around menopause, what used to be called DUB.
But other causes too?
Yes. During childbearing years, it often signals complications of early pregnancy, ectopic pregnancy, abortion complications, submucous polyps, genital malignancies can also present this way. Always needs comprehensive evaluation. Then, postmenopausal bleeding. The source hammers this home. Do not treat this lightly. It's linked to genital malignancy in 30–40% of cases.
That high?
Yeah. So it absolutely requires careful, immediate evaluation to rule out cancer.
Yeah.
Any bleeding after menopause, even spotting, needs full investigation, period.
And bleeding specifically after intercourse, what does that point to?
Postcoital bleeding often immediately suggests a cervical lesion. Could be relatively minor, like cervical erosion or a polyp, but critically, it can also be an early sign of cervical cancer, so another symptom needing timely examination.
Okay. And finally, in this history section, painful conditions and discharge.
Right. Dysmenorrhea, painful periods, and dyspareunia, painful intercourse. These often point to an underlying organic cause in the pelvis.
It's just this.
Common ones include endometriosis, fibroids, PID. These cause inflammation, adhesions, pressure, leading to pain, and vaginal discharge. Very common complaint. Often benign, but frequently a sign of lower genital tract infections needing specific diagnosis and treatment.
Incredible detail just in the menstrual history. Okay,
Yes.
moving on. Obstetric history. How do past pregnancies shape current gynae health? What details are crucial here?
This is vital for connecting the dots between a woman's reproductive past and her present. Clinicians need details of every conception and its outcome. Full term, preterm, abortion, spontaneous or induced MTP, ectopic.
Every single one.
Every single one. Number of living children, age of the youngest, and critically, any obstetric complications encountered during pregnancies or deliveries. These can cast long shadows.
What kind of complications leave lasting marks?
Things like severe infections after childbirth or abortion, puerperal or post-abortal sepsis, they cause scarring. Postpartum hemorrhage, PPH, heavy bleeding after delivery, obstetric interventions like forceps delivery, soft tissue injuries, cervical tears, incompetent cervix leading to repeated abortions, fistulas, severe perineal tears, eventual genital prolapse.
Even things like incontinence.
Stress urinary incontinence, chronic backache, often traceable back to obstetric events, shows the long-term, sometimes subtle, consequences.
Any really severe systemic impacts from obstetric history that professionals need to be super aware of?
Absolutely. The source points out that severe PPH and obstetric shock can lead to pituitary necrosis damage to the pituitary gland in the brain, causing Sheehan syndrome.
Wow, that's serious.
Very serious. Leads to hormone deficiencies. It reinforces a key message. Many chronic gynae problems start with inadequate or complicated obstetric care earlier in life. Underscores the interconnectedness of her entire reproductive life. Need that holistic view for expert care.
Okay, last part of history taking. Abdominal pain. Super common, but signals so many things. What key associations help clinicians narrow it down?
Abdominal pain is critical, yeah. Its character, location, timing, associated factors all provide clues. Chronic abdominal pain, long-standing, persistent. Think pelvic TB, PID, endometriosis, often ongoing inflammatory processes.
Okay.
But acute lower abdominal pain, sudden, severe, that often flags more urgent conditions. Ectopic pregnancy, torsion or rupture of an ovarian cyst, intensely painful. A ruptured chocolate cyst.
Endometrioma.
So differentiating acute versus chronic is key.
Absolutely. That distinction plus associated symptoms helps narrow the possibilities rapidly, guides immediate action.
So after gathering that incredibly detailed history, the physical exam begins. What's the overall structure, and what's that critical point about patient comfort and ethics again?
Right. The exam is structured systematically. 3 main parts: general physical exam, systemic exam, and then the specialized gynecological exam.
And that critical detail, echoing the ethics part, the absolute necessity of having a female attendant present, especially if the clinician is male, assists, reassures the patient. Directly ties back to privacy, respect, making the patient feel safe. Non-negotiable.
Good. Let's start with a general physical examination. For that mastery level, what basic vitals and initial observations give big clues even before the specific gynae part?
This initial look gives you the broad strokes, often high-yield info right away, recording height, weight, pulse, blood pressure, the basics.
Vitals.
Then observations. Pallor, paleness in mucous membranes, tongue, skin, nails, suggests anemia, fullness in the neck, could be thyroid enlargement, enlarged lymph nodes neck, groin, might signal chronic infection, TB, even cancer metastasis.
What else? Swelling.
Bilateral edema, swelling in both feet, can happen with very large abdominal tumors pressing on veins. But unilateral, non-pitting edema, one leg, doesn't indent when pressed. That's more concerning. Highly suggestive of malignant growth blocking lymphatics, a bad sign.
Any other general observations that point towards gynae issues?
Yes, definitely. A comprehensive breast exam must be included, essential part of women's health assessment. Hirsutism, excess male pattern hair growth, classic sign of PCOD, androgen excess.
Yeah.
Any breast secretion, milky or otherwise. Important to note, can be seen in hyperprolactinemia, which is linked to amenorrhea sometimes. These general findings are often crucial early pointers.
So it really is about looking at the whole patient. But that leads to the systemic examination.
Yeah.
How comprehensive does this need to be? What are you looking for?
The source says all gynae patients must be examined as a whole, because gynae issues can link to or impact other systems. So you examine the cardiovascular system, heart sounds, rhythm, respiratory system, lung sounds, breathing.
Neurological.
If they report neurosymptoms, yes, a detailed exam. Otherwise, testing reflexes usually suffices. And crucially, palpate the liver, especially if you suspect malignancy, checking for metastasis, spread. It ensures no systemic condition is missed. Complete clinical picture.
Now, the abdominal examination. Often where gynae issues show up physically, how do clinicians use inspection, palpation, percussion, auscultation to get clues? Let's break down each technique for that deeper understanding.
Right. It's a systematic process, very skilled. Let's take each one. First, inspection, just careful looking.
What do you look for?
Gynae tumors often grow up from the pelvis, so you might see enlargement, especially lower abdomen below the belly button. Upper and side margins might be visible. Really large tumors can enlarge the whole abdomen. Some ovarian cysts, like pseudomucinous cystadenomas, can get enormous mammoth proportions, the source says, can even cause breathing problems from the pressure.
Wow. Anything else on inspection?
A version of the umbilicus belly button sticking out means raised intra-abdominal pressure. Seen with big tumors, ascites, fluid, pregnancy. Watch how the abdominal wall moves with breathing. With a tumor, the wall moves over it. Restricted movement below the belly button suggests pelvic peritonitis, inflammation down there. And striae, stretch marks common after childbirth with obesity or large tumors.
Okay, inspection done. Then palpation, feeling the abdomen. How's that done?
Clinicians usually on the patient's right. Palpate liver, spleen, kidneys first, right hand. Then, for pelvic swellings, use the sensitive ulnar border, the little finger side of the left hand. Feel from above downwards for masses rising from the pelvis. You can usually feel the upper and side edges, but the lower border is deep in the pelvis, often unreachable from the abdomen.
What specific feelings point to different conditions? How do you differentiate?
Good question. Myomas fibroids usually feel firm, smooth surface. Unless there are lots, then it might feel bossed or irregular, lumpy.
Okay.
Ovarian neoplasms often feel cystic, maybe fluctuant, like fluid inside. Upper edge, usually well felt unless it's huge. A pregnant uterus. Feels soft, but hardens intermittently with Braxton Hicks contractions. Characteristic. A full bladder bulges, feels tense, tender, can mimic a mass.
What about tenderness?
Extreme tenderness below the umbilicus. Big red flag. Suggests peritoneal irritation. Seen in ectopic pregnancy, PID, twisted ovarian cyst, rupture corpus luteum hematoma, red degeneration in a fibroid, often during pregnancy, acute surgical conditions. You'll feel guarding rigidity on deep palpation. Serious signs.
Got it. Next, percussion tapping the abdomen. What does that tell you?
Right. Uterine myomas, ovarian cysts, they sound dull when you tap over them because they're solid or fluid-filled. But the flanks, the sides, should stay resonant hollow sounding because of gas in the bowel there.
What if the flanks are dull?
Dullness in the flanks and shifting dullness where the dull sound moves when the patient turns that strongly indicates free fluid in the abdomen.
Ascites?
An ascites means?
Could be tuberculous peritonitis, malignancy, especially ovarian cancer, or pseudomeg syndrome. Serious possibilities.
Okay. Finally, auscultation listening with a stethoscope. Primarily listening for bowel sounds, normal peristalsis, gurgling. In pregnancy, you might hear fetal heart sounds. A soufflé soft blowing sound can be heard with vascular tumors or a pregnant uterus due to high blood flow.
What are the abnormal sounds?
Hyperperistalsis superactive sounds. Could be bowel obstruction, feeble or absent sounds. Suggest ileus bowel not moving, needs urgent attention. After pelvic surgery, hearing those bowel sounds return, that's a very welcome sign of recovery. Means you can start oral feeding.
Incredibly systematic.
Oh.
Hey, let's move to the gynecological examination itself, often the most sensitive part. Preferred positions.
Yeah.
And that crucial consent reminder again.
Yes. The dorsal position on the back, knees bent, legs apart is most preferred. Very practical. Allows easy transition from abdominal to pelvic exam without repositioning.
Some prefer Sims.
Some clinicians do left lateral position, especially for assessing prolapse, but regardless of position, absolutely critical. Get verbal consent before the bimanual exam. Reinforces autonomy, respect, non-negotiable. The exam starts with examination of the external genitalia. Needs good light. Note pubic hair distribution, usually an inverted triangle. Upward extension towards the belly button, seen in about 25% of women, especially if he arsute, maybe PCOD.
Okay.
With the patient in lithotomy, legs in stirrups, thighs parted, examine the vulva structures. Look for discharge, blood, lesions, inflammation. Ask her to bear down, push like having a bowel movement.
Just see what.
See if anything protrudes a polyp. Or any genital descent, cystocele, bladder prolapse, rectocele, rectum prolapse, uterine descent, even full procedentia, uterus outside. Then gently separate the labia, check the fourchette, the back part, see if it's intact or has old tears, maybe from childbirth.
Next up.
Speculum examination, ideally done before the bimanual vaginal exam, especially if you need a pap smear or vaginal smear. Because fingers from the bimanual can remove cervical cells, false negative pap. Lubricants can interfere with detecting microbes. Bleeding can obscure the view.
Makes sense. What kinds of speculums are used?
Two main types mentioned. Cusco speculum, bivalve, self-retaining, two blades, hold itself open, freeze up hands. Ideal for office exams. Good view of cervix, allows pap collection, discharge sampling from posterior fornix, colposcopy.
Okay. And the other?
Sims vaginal speculum. Used with an anterior vaginal wall retractor, needs an assistant to hold it. Allows assessment of vaginal walls for cystocele, rectocele. Patient needs to be right at the edge of the table.
Special note about incontinence.
Yes. Stress incontinence leaking with coughing, sneezing, look for it, especially if there's prolapse. Examine with a full bladder to try and provoke it.
Okay, speculum done. Then the bimanual examination, the core pelvic assessment. How's it performed?
After separating labia, left hand, two lubricated fingers, index and middle right hand, gently inserted into the vagina, reaching the fornices around the cervix.
Clues to uterine position here.
Yes. If you feel the anterior lip of the cervix first, it usually means cervix points down and back, uterus is anteverted, tilted forward. Feel the posterior lip first. Suggests a retroverted uterus, tilted backward. Then assess cervix consistency, soft in pregnancy, firm otherwise. Note if moving the cervix causes pain, cervical motion, tenderness. That's a red flag for things like ectopic pregnancy or acute pelvic infection, salpingo-oophorytis. Indicates peritoneal irritation.
How do you feel the uterus itself?
Vaginal fingers lift the cervix up, elevating the uterus towards the other hand placed on the lower abdomen. Brings the uterus between your two hands.
This allows you to feel what?
Position, size, shape, mobility, tenderness, any pathology like fibroids. A retroverted uterus won't be felt easily abdominally, but you'll feel it through the posterior fornix.
What about masses beside the uterus? Head and nexal masses.
Direct examining fingers into the lateral fornices. Lift towards the abdominal hand. Feel for masses separate from the uterus.
Common things found there.
Ovarian cyst neoplasm, parovarian cyst, like a fimbrial cyst, tubo-ovarian masses infection, hydrosalpinx, fluid-filled tube, chronic ectopic pregnancy swelling, important. Normal tubes and ovaries usually aren't palpable unless enlarged. Feeling the ovary itself often causes a specific sharp pain, useful clue.
Okay. Then palpating the pouch of Douglas.
Yeah.
Through the posterior fornix.
Yes, that space between rectum and uterus, most common thing felt there. A loaded rectum, especially if constipated. Easy mimic of pathology.
Other possibilities. More concerning ones.
Diminishing frequency. Retrovoted uterus, prolapsed ovaries, fibroid, ovarian neoplasm, chocolate cyst, endometrioma, endometriotic nodules, inflammatory masses, adhesions from PID, pelvic abscess, pelvic hematocele, blood collection, often from ruptured ectopic. Lots can hide there.
How do you tell the uterus apart from an adnexal mass for sure? That seems critical for a professional.
Absolutely critical skill. Push the cervix upwards with vaginal fingers. If that movement is transmitted to the mass felt abdominally, it's the uterus. Or push down on the uterus from the abdomen, the cervix moves down. The key differentiator, an adnexal mass, being separate, does not move with cervical or uterine movement. That independent movement is crucial.
Okay. Lastly, the rectal examination. When is this used?
Avoid an inversions there. A lubricated finger in the rectum can assess pelvic structures bimanually. But nowadays, ultrasound is generally preferred over rectal exam for routine assessment.
Why?
Ultrasound is less unpleasant, more accurate, gives better visualization.
So when is rectal exam still useful or even mandatory for that mastery level?
Still very useful if there's palpable pathology, specifically in the pouch of Douglas. Often helps identify ovaries better there. In conditions like parametritis, inflammation around uterus, or endometriosis, the uterosacral ligaments often feel thickened, nodular, tender on rectal exam, unique tactile info.
Crucial for cancer staging.
Yes. It confirms if the swelling is in front of the rectum and if the rectum is stuck to it. Vital for assessing posterior spread of cervical cancer, and absolutely mandatory if the patient has rectal symptoms. Start by inspecting the anus, fissures, fistulas, polyps, piles, then maybe use a proctoscope. So while ultrasound reduced its routine use, it's still key for specific things, especially cancer staging and endometriosis assessment. Provides info other methods might miss.
Okay, after that incredibly thorough history and exam, which sounds like it should pinpoint most issues for an expert, what's the precise role of investigations then? Why are they still needed? What do they add?
Excellent question. Because yes, clinical assessment often does clinch the diagnosis or narrow it down significantly, but investigations are necessary for several critical reasons.
Such as?
1, to confirm the tentative clinical diagnosis with objective evidence. 2, assess the exact extent of the disease vital for staging, planning treatment, especially cancer.
Okay.
3, establish a baseline for future comparison. How do we know if therapy is working if we don't have a starting point?
Right, measuring progress.
And finally, 4, determine the patient's fitness for surgery. Make sure they're healthy enough for the procedure, minimize risks. So investigations augment, validate, refine the clinical picture. They don't just replace clinical skill.
Our source gives a really interesting age-based breakdown of common GYN disorders. Seems like a practical roadmap for clinicians. What are some patterns across the lifespan?
Yeah, this is very practical. Helps anticipate common issues, guides diagnostic thinking, connects things to the bigger picture.
So for adolescent and prepubertal girls?
Common things: vaginal discharge, often infection or irritation, not necessarily STD. Growth disorders, precocious, early, or delayed puberty. STDs can occur, unfortunately. And though less common, tumors of ovary, vagina, vulva.
Reproductive age, menarche to menopause.
Much wider range here due to hormones and reproductive activity. Menstrual disorders galore, ectopic pregnancy, abnormal uterine bleeding, contraception issues, infertility, big one, needs detailed workup. PID is common. And malignancies, gestational trophoblastic neoplasia, GTN, cervical cancer, ovarian tumors are significant concerns. High vigilance needed.
And finally, menopause and postmenopausal age.
Things shift again due to falling hormones, aging, menopause symptoms, hot flashes, vaginal dryness, prolapse of uterus pelvic organs, more common as muscles weaken. Postmenopausal bleeding, crucial symptom, demands immediate investigation for malignancy.
Because the risk is higher then.
Much higher. And malignancies like cervical, endometrial, ovarian, vulval cancer are more prevalent. Systematic screening, prompt investigation are paramount. This age roadmap really helps focus the clinician's expertise.
Now let's dive into the specific lab and screening tests. The ones that confirm suspicions, give deeper insights. What are tumor markers, and what else do we test for in the lab?
Right, these are sophisticated tools giving biochemical, cellular info beyond physical exam. First, tumor markers.
Substances in blood, urine, tissue elevated with certain cancers. For suspected ovarian adenocarcinoma, CA-125 is common, but important for professionals. CA-125 can be high in benign conditions too, like endometriosis, PID, so it's for suspicion, monitoring, not a standalone diagnosis.
Other markers.
For suspected ovarian teratoma, other germ cell tumors. CEA, carcinoembryonic antigen, alpha-fetoproteins, beta-HCG. These give specific clues to the tumor type. Next, bacterial examinations of the genital tract, crucial for IDing infections causing discharge, pain, guides targeted treatment.
How do you test for specific infection?
For trichomoniasis, examine discharge under microscope. Candida yeast, 10% KOH smear dissolves debris, makes yeast easier to see. Staining trichomonads specifically. 1% brilliant crescel violet, gonorrhea, collect discharge, urethra, Bartholin's ducts, endocervix with platinum loop, culture on chocolate agar, chlamydia, immunofluorescent exam of cells, or more commonly now, NACE, nucleic acid amplification tests, bacterial vaginosis. Look for clue cells microscopically.
Specific culture media mentioned. Yeah, Feinberg-Whittington for trichomonad, Nickerson-Sabarad for Candida, and advanced tech. PCR staining is now huge for diagnosing infections highly sensitive. Specific detection of microbial DNA. Big step forward.
What about a hanging drop preparation? When's that used? What does it show?
Hanging drop is mainly for women with leukonuria vaginal discharge. Collect discharge from posterior fornix, suspend a drop in saline on a slide, cover slip, immediate microscopy.
What's normal versus abnormal?
Normal. Exfoliated vaginal cells, large rod-like lactobacilli, daughterlands bacilli, the good bacteria. Abnormal. You might see motile flagellated Trichomonas vaginalis swimming around. For yeast, candida, add 10% KOH to dissolve debris, then look for hyphae budding spores. For bacterial vaginosis, look for those clue cells, epithelial cells coated in bacteria. Gives immediate visual clues to the cause.
Okay, now the big one. The Papa-Nicolau test, the PAP test. Cornerstone of cervical cancer screening. For that elite professional understanding. Its history. How exactly does it work? Strengths? And importantly, limitations. Optimal use.
The PAP test, yeah, truly remarkable screening tool. First described by Papa-Nicolau and Trout, 1943, sometimes called surface biopsy or exfoliative cytology, collects cells shed from the cervix surface.
Cytology meaning study of cells.
Exactly. It's routine in gynae exams for early detection. Guidelines suggest sexually active women over 21 get checked regularly, PAP every 3 years usually, depending on risk history.
What does it detect?
Primarily pre-malignant and malignant changes in the cervix. Can sometimes spot infections too, but crucially it is only a screening test.
Not diagnostic on its own.
Correct. A positive or abnormal result means suspicious cells found, but requires further investigation to confirm. That means colposcopy, magnified view, cervical biopsy, tissue sample, maybe fractional curettage.
How accurate is it?
It detects maybe 60–70% of cervical precancer and cancer. Less reliable for endometrial cancer, under 70%. Reliability heavily depends on good slide prep and the cytologist's skill.
False negatives.
A single test has maybe a 10–15% false negative rate. Abnormal cells present but missed. But that drops to only 1% with repeated tests over time. Shows why regular screening is vital. False positives can happen with infection inflammation. Yearly negative for 3 years is reassuring, then maybe every 5 years is okay, depending on guidelines risk.
Any specific patient instructions beforehand? Things to do or avoid for best results. Crucial for professionals to advise.
Yes, very important pre-test considerations. Tap smear should be done before the bimanual vaginal exam.
Why that?
Fingers might remove the cells needed false negative. Lubricants can interfere or obscure cells. Bleeding makes visualization hard. Also, advise patient. Avoid intercourse, douching, vaginal products for 24 hours beforehand can alter the cellular picture. Best time is around ovulation, but any time is okay if these factors are controlled.
Walk us through the procedure. How are cells collected and prepped every step?
Patient in dorsal position, labia parted. Cusco speculum inserted gently, no lubricant. Visualize the cervix. Focus on the squama-columnar junction, the transformation zone. That's where most cancers start.
Vital zone.
Absolutely. Scrape this junction carefully with an air spatula, rotating all around. Get a good sample. Spread scrapings evenly on a glass slide. Immediately fix it, preserve cells, prevents drawing artifacts. Usually dip in alcohol or mix or use a fixative spray. Then air dry, stain, pap stain.
How do you know if the sample is good enough?
A slide is considered satisfactory if you see endocervical cells. Confirms you got the transformation zone. Often an endocervical brush sample is added too for better predictive value. Ensures sampling from the whole critical area. Then, a cytological evaluation. Trained cytologist looks under microscope. Normal smear shows various cell types. Small basal cells, larger middle layer squamous cells, mature pink superficial layer cells with pynotic nuclei. Might also see normal endometrial cells, immune cells, bacteria.
What screams malignancy at the cellular level? The precise features for a pro.
Malignant cells look very different. Hyperchromatic nuclei stain very dark due to excess abnormal chromatin. Nuclei vary wildly in size and shape pleomorphism, and critically, tiny amount of cytoplasm relative to the nucleus. The nucleus to cytoplasmic ratio is weighed up. Large, dark nucleus dominates the cell. Clear signs of uncontrolled growth. Over time, classification systems evolved. The old Papanicolaou classification had grades the first to V, normal to malignant.
But newer ones are used now.
Yes, much more precise. The Bethesda classification is standard now. More detailed, actionable language classifies as normal, inflammatory, low-grade squamous intraepithelial lesion, LSIL, that's CIN, mild dysplasia, often HPV-related changes, high-grade squamous intraepithelial lesion, HSIL, CIM2, carcinoma in situ, more serious precancerous changes, malignant cells.
More categories.
Yes. Sample adequacy. Atypical squamous cells, ASC, either undetermined significance, ASCS, or can't exclude high-grade, ASCH. Directly identifies squamous cell carcinoma, adenocarcinoma. Much more granular report for guiding follow-up.
Big improvement. Special considerations. Postmenopausal women. Post-radiation.
Yeah. Incidence varies. In postmenopausal women, low estrogen can make the squamous-columnar junction retract, hard to sample. A short course of estrogen cream can help expose it better. Post-radiation cytology is tough scarring. Atrophy makes sampling hard. Interpretation complex. Cells look weird from radiation, hard to distinguish from malignancy sometimes. Big advance. Liquid-based cytology. Cells rinsed into liquid vial, not spread on slide. Better preservation, clearer sample, considered superior. Plus, the liquid can also be used for HPV testing the virus causing most cervical cancer. Links cell screening and virus screening. Major step forward.
Beyond PAP, what other visual methods or cytology evaluations add layers?
Other pathways exist, valuable in different settings. Visual inspection after acetic acid, VIA, simple, low cost. Apply 3-5% acetic acid to cervix. Abnormal areas turn aceto-white. Helps detect potential CI neoplasia, great for screening in low-resource areas. Schiller test, visual inspection after Lugol's iodine valoi. Based on glycogen in normal cells, apply Lugol's iodine. Normal glycogen-rich areas stain mahogany brown. Unstained areas lack glycogen or abnormal. Need biopsy. Simple visual indicator. Cytohormonal evaluation. Vaginal cells reflect hormone influence. Estrogen, progesterone. Estrogen-dominated smear. Clean, discrete, mature cells. Progesterone-dominated. Clumpy, intermediate cells. Pregnancy. Intermediate navicular cells. Postmenopause. Thin mucosa, basal parabasal cells. HPV infection. Can see coilocyte-specific cell changes. Gives a hormonal snapshot. Related to that is the karyopenitic index, KPI or maturation index. Ratio of mature squamous cells to intermediate basal. High KPI, 25% in proliferative estrogen phase. Low in secretory progesterone phase, pregnancy. High KPI in pregnancy, 10% might mean progesterone deficiency. Peaks around ovulation. Finally, uterine aspiration cytology. Used for screening endometrial cancer, especially in postmenopausal women on HRT. Syringe or brush gets endometrial sample. Office procedure claims about 90% accuracy. Good tool for endometrial assessment.
That's deep into the cells. When things are still complex or unclear, what are the next steps for visualization? Advanced imaging, endoscopy.
Right. Then we move to direct visualization or highly detailed imaging. First, colposcopy. Binocular microscope, 10-20x magnification. Great for locating abnormal areas on cervix vagina after positive PAP. Allows accurate, directed biopsies. Reduces false negative biopsies. Lessens need for conization, the surgical cone biopsy, which has risks like bleeding. Guides more targeted, less invasive treatment. Endometrial biopsy. Used to be popular for infertility workup, checking for ovulation via secretory endometrium. Fine curette gets small sample of lining. Now, ultrasound is mostly used for ovulation detection, so biopsy less common for that.
Still used sometimes?
Yes, if suspecting tubercular endometritis or for diagnosing corpus luteal phase defect, niche uses remain. Hormonal assays, modern tests, radioimmunoassay ELISA, measure hormone levels precisely. FSH, LH, prolactin, TSH, T3, T4, progesterone, oestradiol, testosterone, HCG, many others. Diagnosing menopause, PCOD, prolactinomas, essential for monitoring ovulation induction, IVF treatments. Crucial physiological data. Ultrasonography, huge tool. Simple, non-invasive, painless, no radiation. Scan pelvis, lower abdomen, longitudinal and transverse planes. Transabdominal scan usually needs a full bladder.
Yeah, full bladder.
Lifts uterus out of pelvis, pushes bowel gas aside, creates an acoustic window for better imaging.
But the transvaginal probe offers more detail.
Right, exactly. Transvaginal probe gets much finer detail, closer view. Bladder doesn't need to be full. Ultrasound's power is immense, confirms clinical findings, often uncovers unsuspected issues. Newer routes too, rectal, perineal, and 3D ultrasound gives three-dimensional images great for congenital malformations, less costly than MRI. Ultrasound is also used therapeutically guiding IVF egg retrieval, aspirating cysts or abscesses. Very versatile. Other imaging modalities exist too. Hysterosalpingography, HSG, uses contrast dye and X-ray to check fallopian tube patency for infertility. For detailed tumor assessment extent, spreads, CT scans, and MRI are invaluable. Advanced cross-sectional imaging, sonosalpingography uses saline ultrasound for infertility or suspected polyps, and gynecological endoscopy, direct visualization, laparoscopy scope through small abdominal incision to view pelvic organs, great for endometriosis, adhesions, ovarian cysts, hysteroscopy scope through vagina cervix into uterus, views uterine cavity for polyps, fibroids, abnormalities, often allows diagnosis and treatment in one go, definitive view when needed. Finally, the simple pregnancy test, usually urine test for HCG. Modern kits are very sensitive, positive very early, maybe 1-2 days after missed period. Crucial for ruling out pregnancy in many situations.
Wow. That was an incredibly thorough deep dive. The entire process, ethics to advanced tech, really covered the ground needed for that mastery level.
Indeed. And the takeaway. Most gynae diseases can be diagnosed with that proper detailed history and skilled pelvic exam, utmost care for patient feelings, privacy, using simple words for sensitive topics, sexual history, contraception, etc. That's fundamental for trust.
And it's clear the modern toolkit is vast. Investigations confirm, assess disease extent, help plan management. They're crucial additions.
Precisely. Pap smear, vital screening for cervical cancer. Ultrasound, simplified diagnosis, immensely non-invasive view.
Endoscopy for when you need that direct look.
Right. Selective endoscopy for definitive diagnosis. Hormonal assays for infertility, IVF, hormone issues, and CT/MRI when diagnosis is still tricky after physical exam. They've massively enhanced imaging. Hashtag outro and
So we've navigated the really intricate world of gynecological patient care. From that ethical bedrock, establishing trust, all the way to the cutting edge of diagnostics. You've seen how every piece fits the patient's own words, the cell details on a pap smear, building that holistic, professional-level understanding.
So what's the so what? What does this mean for you, our listener, after this deep dive? It means recognizing that expert care isn't just clinical knowledge or technical skill. It's deeply interwoven with empathy, active listening, and that comprehensive, systematic approach. It really highlights the progress in medical tools, but also the continuous evolution of best practices for compassionate care.
And as you reflect on all this, here's a provocative thought. In this era of really rapid tech advancements, AI helping diagnosis, new imaging, how will those fundamental human elements, trust, privacy, respectful communication, continue to shape and define what truly makes elite professional care in gynecology?
Will those human touchstones become even more critical as technology handles more analytics? Distinguishing the truly exceptional care.
It's a fascinating question, right? Underscores that enduring human connection at the heart of medicine.
Absolutely.
Thank you for joining us on this journey to becoming truly well-informed, hopefully mastering this complex area. We really encourage you to carry these insights forward. Maybe explore further any areas that sparked your curiosity today.
Keep asking questions.
Exactly. Until next time, keep diving deep.